Of knowing, perceiving, recognizing, conceiving, judging, reasoning, and imagining. It's all of those thought processes, okay? Basically what we will see is that there is a damage to cognition. It impacts the brain's ability to function intellectually, emotionally, socially, and occupationally. There are three main categories: delirium, dementia, and mild cognitive impairment. Delirium is the one that you guys are probably going to see most often in the hospital. Unfortunately, dementia is rapidly increasing in number. Okay? Delirium. Think of it this way, the difference between the two. Delirium is always, always, always secondary to another condition. And the onset is abrupt. These are your little old folks that come into the hospital because of pneumonia or bowel obstruction. And they get confused and hallucinate in the middle of the night because they don't know where they are. Dementia. It is a primary encephalopathy, meaning that there's something wrong with the brain. Okay? With your dementias, about 80% of those are irreversible, meaning that it's an organic brain disorder. There's nothing that can treat or cure. With your dementias, the onset is gradual, and that is one of your big keys. Delirium is abrupt, dementias are gradual. Mild cognitive impairment is usually memory difficulties, and often that occurs because you may have a bump to the head or some type of illness that way. Typically what you will see is that delirium can occur at any stage in the developmental process. Typically they think that children are more susceptible to delirium than adults. Particularly when they have a fever or they're exposed to anticholinergics. With children, one of the most common indicators of delirium is the inability of familiar objects or familiar persons to soothe that child. In other words, if that child has a whoopee that they have always carried around, and that's what puts them to sleep, whoopee is no longer their best friend. And they cry, and they're upset. Or mom or dad can't soothe them. Their caregiver can't soothe them. Typically what you will see is that is one of the indications that this child is experiencing delirium. Okay? Now, with older adults, what you typically see is that chronic medical problems may cause a delirium because of fluid and electrolyte disturbances. Remember, serum sodium can cause a delirium, either elevated or low. Dehydration can cause delirium. Now, polypharmacy. Remember, the average older adult takes anywhere between 5 and 7 prescription medications. When you add in the over-the-counter, you're talking probably 12 to 15. Unless they're on IP, they're on 30. Those of you that passed meds on IP, you know what I'm talking about. The more drugs that you add to that patient's prescription and over-the-counter list, the more likely they are to develop delirium based on that. The other thing that you will see is that under-treatment of pain may contribute to delirium. Hearing or vision loss is another biggie. I'll give you an example. They did a study in a nursing home, long-term care facility, where they had 30 patients that were diagnosed or termed confused by the nurses. What they did is that they went through and cleaned out everyone's ears that would build up with wax. After that intervention where their hearing improved, out of that 30 that were confused, only 2 remained confused.
Oh, that's cool.
Only 2. So vision or hearing loss can greatly contribute to the delirium. Because if you can't hear, you can't see, often you imagine things in your environment. Now, some other things that you'd want to remember with your older adults. The most common cause of delirium in your elder adults is going to be infection. If you've got someone that is confused, look to make sure that they don't have a urinary tract infection. Make sure that their oxygenation is sufficient. Hypoxia is one of the most common causes of delirium in your postoperative patients. Make sure you do that assessment. What's their pulse ox? What's their hemoglobin hematocrit? Remember, if you've got a patient with a low hemoglobin hematocrit, it doesn't really matter what their pulse ox is, because what they've got may be 100% saturated. But if their hemoglobin is 6, they don't have enough blood cells to carry the oxygen to those tissues. Okay? Electrolyte imbalances. Again, sodium, potassium, calcium, those things we want to make sure. Those are some of the comorbid conditions that you see that contribute to delirium in these patients. Subtle signs from forgetting what you're doing. You ever had that little feeling where you came into a room and then you can't remember what you were coming into the room for? And you have to walk back to where you started to remember what it is?
Yeah.
That's normal. Don't worry about that. But with delirium, it typically gets a little bit stronger than that. You may see fluctuations in alertness with these folks, meaning that they may be sleepy and difficult to arouse to alert, or sometimes even hypervigilant, okay? These are the people that have the scary eyes that don't sleep, and they watch whatever's going on. These people may have difficulty sustaining attention, and they have extreme distractibility. Think of ADHD on steroids, okay? Basically, you put a food tray in front of them, one bite, and then put it down, and they're doing something else. You need to eat. You take one more bite, put it down, and do something else. When it gets severe, you will see hallucinations, typically auditory and visual with these folks. Now, Sundowning, I think you've all heard about, is a type of delirium. And the closer that the evening, you get to evening or the sundown, the more confused and agitated that client becomes. But during the day, they seem to be okay. Well, I'll tell you guys, if you look outside, there's no sunshine right now. Sundowning syndrome occurs during the daytime on cloudy days. And the cloudier and darker it is during the day, the more significant those symptoms are going to be. Why do they think sundowning occurs? What usually happens when the sun goes down, other than Kenny Chesney? What inputs do you get?
Time to go to bed.
Basically, what you're going to see is that your sensory input is going to lessen, right? Okay, you get quieter, you get stiller. Hopefully everyone is in bed. But typically what happens is that with these patients that have this period of delirium, they need that sensory input to maintain. And when they don't get that sensory input, their body starts making it up. They start hearing things. They start seeing things. They get very much confused with what's going on. This is a way of looking at your assessment. Any change in a patient's mental status needs to be aggressively evaluated. You don't want to say, well, they'll be better in just a minute. Figure it out what's going on with them. Look at your labs. Look at what's going on. Sometimes what you'll find is that delirium can come from overstimulation. There's too much input, and they have no way to filter it out. But a lot of times, especially with sundowning, it's because there's not enough sensory information. Typically what you'll find is look at your confusion assessment. Is it acute onset or is it fluctuating? What is their level of inattention? How disorganized is their thinking? Is there an altered level of consciousness? Remember that sometimes depression can be there. It can be masking the delirium, or sometimes delirium can be diagnosed as depression. They say that probably 75 to 80% of people that are in the hospital, that are in ICU, experience delirium. However, only about 40% of the people that experience it are diagnosed or recognized, either by nursing staff or physicians. So it's one of the things that we need to be vigilant about, making sure that we look for. This is just a confusion assessment scale. I just included it to just give you an idea of what it looked like. Don't worry about memorizing it, because I know you're not going to need it. What I do want you to know is talk about these altered level of consciousness. Okay? Vigilant means they're hyper alert. Lethargic, they're drowsy but easily aroused. Stupor, difficult to arouse. Or coma, unarousable. And what you will find with your patients with delirium is they will often have altered level of consciousness. And that is a significant sign versus whenever you're talking about someone that has dementia. Your patients with dementia do not have an altered level of consciousness. They're alert, pleasantly confused to start off with. But your patients with delirium will have a change in that level of consciousness, and it should be evaluated. Now, some of your assessment findings. Autonomic hyperactivity. What do I mean by that? High blood pressure, high pulse rate, high respiratory rate. Why do you think they're going to have that autonomic hyperactivity? They're anxious, exactly right. All right? I don't know what's going on with me. I'm seeing things. I don't know where I am. I don't know what's going on. So anxiety can be one of your big things that will contribute to that autonomic hyperactivity. Hypervigilance, again. I'm scared. I don't know what's happening. Why are they coming in my room? What is she getting ready to do? Labile mood swings, agitation or anger may occur. Their environment, the perception is disrupted. They may think they're at home. They may think that there's some in jail. We used to have this little lady that would sundown pretty much every evening and call 911 because somebody locked her in her room. So it got to the point where the police would call the hospital operator would call us. Couldn't take away her phone. But we can make it conveniently unavailable sometimes after she'd done 3 911 calls straight in a row. I just get a little anxious about that, and I cannot say that I blame them. Nursing diagnoses that you see. Risk for injury. Safety is going to be one of your key things you're going to look for. Disturbed sleep pattern, insomnia. Again, because of that hypervigilance, they're not going to be able to sleep very well. What happens if you're unable to sleep or you have insomnia? What does that do with someone that has delirium already?
Makes it worse.
It's going to make it worse, okay? Because remember, we all know that if you don't sleep well, you cannot cognitively function well. So that is going to contribute to it. One of the things that happened to my mom while she was in the hospital was that after her heart attack, the nurse kept saying she's not sleeping at all. And I said, do you have the TV on? No, because it's our policy to turn it off at 11 o'clock every night so some people can sleep. I said, my mom sleeps with the TV on all night long. Turn the TV on. They did, and she slept for the first night. So what you have to do is sort of figure out some things that will help with their sleep. If they've always taken a shower or a bath before they got in the bed, that might help with some of the problems that they have with difficulty falling asleep. So you sort of have to be a little bit of a detective to figure out some of these things. Fear. What's the difference between anxiety and fear? As a nursing diagnosis, you have any idea? Anxiety is a perceived threat, generalized perceived threat, and fear is there is a specific perceived threat. It's usually more significant than anxiety, And fear isn't often a diagnosis that you see with your patients with delirium because, you know, there's all these people holding me down and I don't know what's going on. What we hope is these are their outcomes. Absence of confusion. Nursing priority is patient safety, okay? These are people that you reality orient, just like you do with my patients with head trauma. Calendar in the room, clock in the room. We want a consistent staff if possible. Meaning that if I'm working for 3 days in a row, I work with the same patient 3 days. Because change in routine is very upsetting. We want very supportive family members because sometimes we want that family member to stay to help keep them in the bed with the least restrictive means possible. Okay? Basically what we want to do communication-wise is keep the distractions to a minimum. Eliminate that unnecessary noise. If you have to talk with that patient, turn the TV down or off. We don't want 42 conversations going on at the same time in that room with other family members or other members of the healthcare team. We want to make sure that you have a readable name tag and you address the person by name or introduce yourself. Clearly, calmly. Focus on one piece of information at a time, and you need to allow for those words to be processed. Remember, this is a person, no matter what age, that is having problems with following through with those brain functions. What you want to do at this point is give them one-step command. Don't say, here's a toothbrush, brush your teeth. How would you say it? What would you do to make it one-step commands?
Brush your teeth.
Wet your toothbrush. Dip it in the water. Hopefully not in the urinal. Unscrew the cap off the toothpaste. Squeeze some of the toothpaste. You know, you see what I'm saying. One-step commands because it makes it easier for these people to process. Big difference between someone that's delusional and someone that has dementia. We want to reinforce reality when that person is delusional. You're in the hospital. It is Saturday. You had surgery. Reinforce reality. You want to talk about familiar things in their life. Hopefully they're able to process those types of things. We've talked about these a little bit, but making sure that you provide for that adequate sleep is going to help them get a little bit better. One of the things to treat that delirious state, though, is you've got to treat the underlying cause. If it is due to high ammonia levels because of liver disease, then you have to treat the ammonia level. If it is because of low sodium level, then you have to treat that sodium level. You treat the underlying cause with medical condition, and hopefully that delirium will go away. If it's that urinary tract infection or pneumonia, you treat the infection, and hopefully that delirious state will subside. One of the things we want to make sure is that if they have glasses and hearing aids, let them wear them. Because remember, we said that visual and hearing loss contributed to the possibility of delirium. Familiar items, and we want that room well lit during waking hours, and we want some source of light at night, again for safety. Okay? Basically, I'll let you look over this. This is some things we've all talked about as we went through, but it's just sort of a checklist that you can use if you have a patient that's experiencing delirium with some of your interventions, okay? So what we want is, at the evaluation stage, did that patient remain free from falls or injury? Because remember, that's one of our big priorities. And did they return to their pre-morbid level of functioning? Okay? So those are things you need to remember about delirium. Pretty much everybody and their brother can experience it at some point in their life. You typically in the hospital will see it a lot of times as a result of medications or after surgery or some type of chronic condition where you're having fluid and electrolyte imbalances. All right, let's take a break and then we'll come back and do dementia. So we can get through it.
We don't even have to worry about eating disorders. I guess.
Remember, we talked about dementia as a process. One of the things that you'll see is that dementia, consider that an umbrella term. Okay, it is a series of symptoms. Now, with dementia, the last time I looked, there are 140 different types of dementia. Okay? However, it doesn't really matter the cause or the type. Typically, you will see some of the same types of problems with these patients with dementia. One of the things that you will see is that cognitively, these people deteriorate. With dementia, as opposed to delirium, dementia patients have no change in the level of consciousness. They're alert. They're just not oriented. Whereas with delirium, it fluctuates. Okay? Dementia, it typically does not. They will have problems with memory, thinking, and comprehension. The majority of your dementias are irreversible. 90% of them are. However, about 5% are reversible. So what we want to do is to make sure that they don't have any problems with drug or alcohol, eyes or ears, metabolic or endocrine disorders, emotional disorders, neurologic disorders, tumors, traumas, infection, or arterial disease. Think about dementia. These are some of the causes that can be reversible. Drug and alcohol effects. Sometimes when you take away that drug or that alcohol, it can be reversed, or at least the progression stopped. What's one of the big drugs in this category that may contribute to dementia? Alcohol. Okay. Actually, what you can see is it's termed an alcoholic encephalopathy, and it can cause dementia. The more that they drink, the more likely they are to develop it. Okay? Again, we talked about the eyes and ears. Cleaning out the ears decrease the delirium. If that consistently stays in place, then it can contribute to the dementia symptom. Tumors. A lot of my brain tumors may cause problems with dementia, as well as some of the infective processes like the encephalitis or bacterial meningitis. Arteriovascular disease. One of the things that you will see is that there's a vascular dementia, and that typically is associated with patients that have high blood pressure that may have very small infarcts in the brain that will contribute to the dementia. Toxoplasmosis, like you get with that parasite from cat litter. Okay, not only can it harm babies, but it also can cause a brain encephalopathy that will cause dementias. Some of the risk factors: age. Okay. Typically, the older that we get, the more likely that we are to develop dementia. Though what's starting to be more scary is that we're starting to see more early onset dementia. People in their 40s and 50s develop disease like Alzheimer's dementia. Gender, more likely in females than it is in males. But they're not really sure if it's due to the fact that there's a predisposition for females, or just because females live longer than males do typically, and they're more likely to be exposed because of age. Now with genetics, we're talking about APOE, E4. It is a genetic component on chromosome 19. APOE is a regulator of cholesterol. And what we can do is test for APOE. If you're found to have this APOE, then the chances are greatly increased that you will have a development of Alzheimer's sometime in your life. There is an early onset. They usually consider that one is genetic or inherited. Typically, there are 3 chromosomes that are involved, and if you have positive markers for all 3 of these chromosomes, the chance that you will develop Alzheimer's, dementia of Alzheimer's type in your early 40s is dramatically increased. The other thing, of course, that will contribute is diabetes. Not necessarily having diabetes, but having out-of-control blood sugars. Okay? Hypertension also contributes, again, because of the vascular insult that that brain gets with hypertension. Now, socioeconomic status, well, even though we see people in all socioeconomic levels, typically what we see is an increase in your clients that are in the poverty level. And it may be for 2 reasons. Number one, they don't have the resources to gain better education, which is one of the protective factors. And it may be that they don't have the resources for medical care to treat the diabetes, to treat the hypertension, to recognize those early symptoms of dementia. Now, let's talk about some protective factors. Never guess what's going to come out of my mouth, but cigarette smoking is a protective factor. So all you smokers, just prevent saying that you're going to preventing your dementia. Basically, a couple of other protective factors are better education and physical exercise. Good diet, low cholesterol diets, because especially if you have that marker for the APOE E4, you want a low cholesterol diet to help decrease some of that marker. The other thing is not only smoking, but drinking at least 3 glasses of wine a week. Protective factor. So those of you who want to get a prescription for your dementia care, I'm sorry, I can't write you one. Now, remember I said dementia is an umbrella term? The majority of what we're going to talk about today is dementia of the Alzheimer's type. It is the most common that you will see. It is probably one of the fastest growing types of dementia that's out there, but just recognize there are other types. The vascular dementia, that's the one that you see from hypertension. There is dementia with Lewy bodies. After Alzheimer's, this is the one that you see most frequency. And Lewy body are just a cell type. Okay? Jakob-Creutzfeldt disease or Creutzfeldt-Jakob disease, sort of like mad cow. Okay, you've heard people talk about that. It's a prion disease. It causes a dementia. The thing that's different between this one and some of the others is that Creutzfeldt-Jakob disease usually causes death within 12 to 18 months after a diagnosis. Okay? Whereas with Alzheimer's disease, we may be talking 10, 15, 20 years. There are other types, but typically what you will see the majority of times are Alzheimer's. Now, this is just a sort of thing that contrasts the two. The thing you need to remember, dementia, slow onset, delirium, sudden onset. Okay? So what you will see with this, again, dementia, no decreased level of consciousness, delirium, fluctuating or changing level of consciousness. That's how you tell the two apart. Now, with Alzheimer's disease, it is a progressive degenerative changes occur in the brain. And typically what you see are these neurofibrillary tangles. And what happens with those tangles being present, you have a loss of communication between the neurons. What happens is that because there's no communication, those neurons die. So you actually have loss of brain tissue. The communication is lost. So therefore, the function does not persist because that tissue dies. The other thing is that you will see are amyloid plaques in the spaces between neurons. This discovery has been, I want to say, probably in the last 20 to 25 years. One of the studies that I participated in as a nurse was one of the studies that discovered those neurofibrillary tangles and the amyloid plaques. What they did is that they were doing rapid autopsies on these patients. So what they had were patients that were being followed in the community with dementia. They thought that it was Alzheimer's because they were unable to make a diagnosis until basically pathology exam on the brain. Basically what they did is when these patients were within what they thought was 24 hours of dying, they brought them into the hospital so that they would die in the hospital. The doctor would be able to pronounce, we'd put them on a stretcher and take them to the rapid autopsy, immediate autopsy. That was something that the patients' families agreed to, part of the research. And it was really sort of morbid because what would happen is that these patients would come in, we'd have the morgue stretcher either in the room or outside the door. immediately after they were pronounced, their brains were autopsied within 1 hour. No, well, families have been grieving for the past 10 years. The actual point, basically 5 minutes and then they're gone type deal. But a lot of the anticipatory grief had already occurred. But what this study did is it discovered those tangles in amyloid plaques. Because what happens is that after the brain dies, this tissue dies, then a lot of these tangles disappear. So they had to do those rapid autopsies in order to be able to see it. Now, what we found is that the death of the neurons follows that very specific pattern. Typically what you will see is that that limbic system, that area that's the center for emotion and memory, is affected first. So that what you often see is that with that limbic system, the hippocampus is affected, so you lose recent memory. That's why your patients with dementia may not be able to remember what they had for breakfast this morning or what you told them 5 minutes ago, but they can remember a lot of things from their childhood. It's because the way that this disease destroys that brain tissue. Remote memory is lost eventually, but it's much more slowly because it's spread over larger areas of the brain. Typically what happens is that blood flow will decrease to those brain areas and you have the atrophy of the cortical areas. And when you start having the atrophy of the cortical areas, that's whenever you start losing the motor, the speech, the sensory function. What happens is this. You get a normal looking brain in size that now becomes extremely atrophied with very, very little connections. This is the way that the brain tissue is lost. So limbic system and hippocampus, remember that's your recent memory. Frontal lobe. What are some of the things our frontal lobes do, guys?
Impulse
Emotions. The ability to inhibit behavior. So often what you will see is that not only do you have what we would term inappropriate behavior, but remember those inhibitory signals are what keeps us continent of urine and stool. Okay? Whenever you potty train a child, you have to train those impulses to hold that urine. With loss of that frontal lobe tissue, then they lose the ability to remain continent. With parietal lobe, that's more like your speech. Temporal lobe, memory, judgment, and hearing. And then lastly, the occipital, vision, or the ability to read with any comprehension. Some of the warning signs are these. Memory loss that affects job skills. Difficulty performing familiar tasks, problems with language, disorientation to time or place. This is one that you see most often is problems with abstract thinking. One of the things that a lot of doctors' offices are doing now as part of the quote-unquote Obamacare or Healthcare Act basically is they're doing screening for all Medicare patients for dementias. And they're doing the testing, having them draw a clock and put the numbers on it. Having them to do some other types of spatial testing because it is one of the ways that you can determine that you will have some starting to have some of those warning signs. Clinically, likelihood of misplacing things, well, that's all of us, but typically we don't put our keys in the freezer. Okay? Changes in mood or behavior, changes in personality. This sweet little old lady may become an evil person. Okay? Typically the evil people don't become nice. I'll tell you, it just exaggerates that. Loss of initiative, and what do I mean by initiative? This is like your patients that are depressed. I don't feel like getting up. I don't feel like getting dressed. I don't feel like making food. Okay? They don't have that drive to do what their normal routines are. The 5 A's that you need to remember: amnesia or memory loss, aphasia, inability to express oneself through speech, agnosia, inability to recognize familiar objects, taste, sounds, and other sensations. They may not recognize what you do with a comb or a brush or toothbrush. Apraxia, they may misuse them. That toothbrush may become a hairbrush. Anomia, inability to remember the names of things. Now that also occurs with stress, but often what you will find is that they're unable to remember what things are called. You place a coin in their hand and they don't know what it is. Now, one of the things that I will see with those is that a lot of people think that, well, I'm just getting old. But look at the difference here between normal aging and Alzheimer's disease. Patients with normal aging, recent memory is more impaired than remote. With Alzheimer's disease, you get both impaired. Normal aging, difficulty in recalling names of people and places. Difficulty versus inability, okay? So there are some things that help. Writing things down is helpful as we age, thank God. But with your Alzheimer's disease, they have that inability to write. And often if you write down a list, they may not be able to read it, or they can't find the list. There is a difference between the two. These are normal. These are something that needs to be investigated. Now what you will find is that typically I've seen references used from 3 stages to 7 stages. Your book goes by 4 stages, so that's what we're going to go over because I don't want to confuse you. Stage 1 is mild, typically 2 to 4 years. These are people that have difficulty learning new things, forgetfulness, short-term memory loss, very subtle changes in their personality, and they have difficulty doing simple calculations. Those of us that have difficulty doing simple calculations without a calculator are doomed from the start, because we certainly can't do it whenever we start developing with Alzheimer's. One of the things that I will tell you with this stage is that sometimes what you will find is that if your patients are depressed, it will worsen these symptoms. So you want to treat the depression, and hopefully some of these symptoms will improve. Okay? Typically in this stage, you may hear things like, you hid my keys. Where'd you put my keys? I know you put things where I can't find them. Okay? Stage 2. Again, it lasts about 2 to 12 years depending on progression. Diagnosis is usually made in this stage. Memory deficits are much more apparent, but they can have periods of lucidity, meaning that if you sit and talk to them for a while, they may be fine, but 15 or 20 minutes later, they don't remember who they are or where they are. Sundowning becomes more common in this stage. Typically what you'll find is that labile mood will occur, hygiene will suffer. Unfortunately, this is the stage where you start seeing some difficulties with getting them in the shower or bathing or getting them to change clothes. Stage 2. Typically what you also see in that second stage are some of the apraxias, meaning that they don't know how to use certain common things like a comb or a brush or a toothbrush. Typically, you start seeing problems with malnutrition in this stage and decreased fluid intake. Remember, it is a normal part of aging that our sense of thirst decreases as we age. But with these Alzheimer's patients or dementia patients, that can be life-threatening because they can become severely dehydrated because of that. Safety is a major issue with these folks. Driving can be a problem. One of the things that is most distressing to your elderly clients with dementias is the inability to drive. Because think of it, guys. What did you gain whenever you were 16 or 17 and gained your driver's license?
Independence.
Independence. Okay? These are the folks that you hear that they get in the car to go to the grocery store and end up in Bristol, Tennessee. Or they get lost. One of the ways that we as nurses can help families is that occupational therapy does driving tests to determine if these people are safe to drive and when the keys should be taken. Typically what you need to tell the family is a word to the doctor, not in the presence of the patient, that you don't think they're safe to drive, and have the doctor to take away the keys, because typically those patients are much more tolerant of that. With my grandmother, one of the things that would happen that we were concerned about with safety is in her generation there's only one speed on that stove, and that is high. Okay? What my dad did while I had taken my grandmother somewhere is he unplugged the stove. Pushed it back just like it was going to be regular stove. So the next time my grandmother tried to cook something, the stove wouldn't work. Well, Daddy finally told her, he says, Mom, I can't fix it. And it costs $3,000 to get a new one. Oh, I'm not doing that. So we gave her a microwave, which she hated, but she learned to use because it was much safer than cooking something on high and forgetting and burning the house down. Okay? Safety is one of those things you need to worry about. Stage 3. Typically what you will see with patients in this stage, they will have progressive loss of cognitive abilities. They may be unable to recognize familiar objects or people. And that is very, very distressing to families. They may need repeated instructions. Agitation, violence, paranoia, and delusions may be common. They often lose their ability to communicate. And often this is the stage where a lot of these patients are placed in long-term care facilities. number one reason for placement in long-term care facility is loss of confidence. Often what you will see with stage 3 is wandering, pacing. What a lot of people think is that wandering behavior is a way to get rid of excess energy. But often you will see that there's some complications that occur because of other behaviors, that pneumonia, because they're more susceptible to infection, dehydration, malnutrition, falls. Again, this third stage is where most are institutionalized. With stage 4 Alzheimer's, the ability to talk and walk is lost. They have hyperorality, meaning that everything goes in their mouth, just like kids during that crawling stage. They have hypermetamorphosis, which means they touch everything. Okay, they're into textures. They're into feeling to see what it is. As this person progresses towards death, you will have a drop in the level of consciousness. Typically what you will see is that death is due to choking or infection with this very insidious disease. Now, look at the difference between depression and dementia, because I told you that some can occur and that the depression can mask. Look at this. Depression, I don't know, is a common answer. Whereas your patients with dementia, they confabulate. And what does confabulation mean? Make up stuff. Just like you guys do whenever we ask you a question clinical. You may not know, but hopefully I'm going to nod my head whenever you hit some of the right answers. And a lot of these people do that because they're able to pick up those body clues. If you hit on the right thing and that you nod, they're going to continue in that vein until they run out of something to say, and then they're going to, okay, I did it. Okay? It's the difference between the two. Impaired attention span. Affect is labile. They're disoriented. Whereas your people that are depressed, they may have a normal attention span, but they're oriented. Okay? Diagnostic tests. There are no definitive tests yet. However, this past July, the world sort of had this, maybe this is going to be it. Because what they found is that people that have a decreased sense of smell, it's called the peanut butter test. If someone was not able to smell peanut butter from a length of 2 feet, those people were more likely to have Alzheimer's or to develop Alzheimer's within the year. It's a very cheap screening tool. However, it was in 2 small studies. What they're looking at now is to make sure that that is the case with everyone. The other thing that they were talking about in this same Alzheimer's conference is an eye test. And what they looked at is just an examination of the retina. And what they found is that people with that ApoE4 tended to have a buildup of cholesterol on the back of their vessels of their eyeball. And it was one of the ways that they may be able to very quickly diagnose Alzheimer's or a dementia. One of the things that you guys need to recognize is that dementia is one of those diagnoses of exclusions. which means that you rule everything else out. And then you say, well, it may be dementia. Okay? PET and SPECT may also be one of those things that sort of helps. Multidisciplinary team is definitely needed. We've talked about a lot of these. Remember your A's whenever you're looking about your assessments with Alzheimer's. Some of the nursing diagnoses, remember impaired memory may be in stage 1, but chronic confusion will be stage 2 and on. As the disease progresses, caregiver role street is going to be one of your biggies. Alright, so what we want to do is to make sure that we target to make sure these people are kept injury-free, that they are able to meet their self-care needs, or if they're not able to do it, that someone else is doing it for them. Pharmacology, I want to touch on because this is one of the things that we're starting to see used more and more. With Alzheimer's disease or dementia, these are not cures, but what we hope and are seeing is that some of these cholinesterase inhibitors and glutamate pathway modifiers may slow the progression. Slowing the progression from that second stage into that third stage. The other thing that we're finding is that some ACE inhibitors, angiotensin converting enzyme inhibitors, may also slow the development of Alzheimer's disease. So if you have a patient that has hypertension, then an ACE inhibitor may be the drug of choice to help with prevention of that dementia that's associated with vascular problems. With all people of age, this is your motto. Start low, go slow. You don't want to put these people on a moderate range of this medication or at the high range. You start at the bottom of the range and gradually work yourself up, because they are more likely to develop side effects from those medications, the higher the dose. Okay, typically what I would tell you is that these drugs are used to treat mild to moderate, usually stage 1 to stage 2 Alzheimer's disease. Some physicians will continue them into stage 3, but typically you find that most people will take them off. They are not cheap. Basically, one of the things you'll see with the anticholinesterases, the Aricept, the Razidine, the Exelon. Exelon, remember, is a patch. These others are meds that are PO. The glutamatergic inhibitors, the Namibia. And often what you'll see is that they may be on both of these agents, okay, because they work different pathways. Now, some other drugs that they're studying right now are insulin and NSAIDs, because they found that taking a couple of ibuprofen may be a protective mechanism. However, taking too many of it may cause GI distress and GI upset and GI bleeding, so you have to worry about that as well. If they have depression, you treat the depression. SSRIs are better tolerated. Now, this is one of the things that you will see, is that a lot of times what you will see is that some of these patients, especially in late second, early third stage, may have behavioral symptoms. in the past, what we did is we gave them these antipsychotic medications. Basically, in 2005, the FDA issued a black box warning that said giving these antipsychotics to patients with dementia greatly increases their mortality. They typically have heart attacks because of this. So the focus of behavioral treatment, instead of giving them a drug now, is more redirection or other types of therapy instead of just slapping another drug on them. But you will see, you know, meds like Abilify, when you hear that commercial, not intended for the use of dementia. Okay, it's because of that black box warning. Now, this one's a new one. It's a medical food. It is called Axona. Basically, what they're thinking is that Alzheimer's disease inhibits the brain's ability to break down glucose. So that what happens on top of that dementia, you may get delirium on top of that. So what Axona does is that it provides an alternative source that the brain can use instead of glucose. It's pre-digested glucose, so to speak. In a very small study, but it's funded by the manufacturer, found that memory and cognition improved for those with mild to moderate Alzheimer's disease. And what they're doing is they're doing further trials that are not funded by the manufacturer of the product to see if in fact that is going to help with that. We'll see. Impaired memory. These are some of the nursing diagnoses that you'll see. Some of the treatments. One of the things that you need to remember is that they carry a wallet card with IDs and phone numbers. The other thing, of course, is that chronic confusion, labeling rooms and doors or things, pictures probably are better than words because they often won't recognize their own name on the room, but they may recognize their face, a picture of them, so that they know which room to go in. Sometimes this is with your patients with dementia. This is where therapeutic communication doesn't work. We want yes or no questions here, okay? We want to orient them to the environment and person and time, but what I'm going to tell you guys, with reality orientation with your patients with dementia,
You don't argue.
you don't want to do that. Because if so-and-so says, well, my mom's coming to visit, and this is a 98-year-old woman, you tell that little lady that, well, your mom's been dead for 30 years. She's experiencing that loss and grief every time you tell her that. So it's cruel. Yes, you reality orient them to, you're in the hospital, we're going to do this. But be careful with how much you do, because the death of a spouse, the death of a family member, again, it's a new loss every time they hear it. That red tape or yellow tape, we use it at LifeWorks to show people where they can go. Repeat explanations as simply as needed to decrease anxiety. And just be aware that you may be given this explanation over and over and over again. Communication. Face them and talk directly to them, because remember, a lot of these patients will have hearing and visual impairments as well as their dementia. Avoid arguing. Won't get you anywhere, and it it's going to make your patient more agitated. Risk of injury. Definitely, we're going to watch out for falls. Evaluate their muscle strength and gait. Remember that a lot of these patients do not recognize that they're so weak they're unable to stand. And they're at greater risk for falls because of that. Wandering can cause its own problems with injury. Double lock door systems to the outside doors often are necessary. We had an Alzheimer's unit that it was a series of, you punch numbers, you turn this way, and you turn this way, and then so that no one had to carry keys. What happened is that after 3 weeks, the nurses couldn't remember the combinations, but the patients could go ahead and get out. So we had to go to keys. One of the things that you do have here available in Cabarrus County is that the Sheriff's Department will provide a GPS, like a bracelet, for a nominal fee. I think they're through Protect for Life, and they're like $5 a month. So that if patients do wander, they can flip on the GPS and find them. You can do the same thing with the cell phone if you can get the person to carry a cell phone. But it will help with a lot of the silver alerts. We talked a little bit about these. Anxiety. Daily routines need to be consistent. It's that change in routine that's extremely upsetting to these clients. The other thing, of course, that can help is line dancing or reading. But this is something, it's called a busy belt or a busy quilt. Basically what it is it's different textures. There are buttons, there's zippers, there's all sorts of things. I know that a lot of people use dolls or objects. It's a safety thing that provides for comfort. Whatever helps with that anxiety is what you want to use. One of the things that we used to do in the hospital is give someone a stack of washcloths and have them fold the washcloths. You take the washcloths outside the room, you mess them up again. Oh, I got more laundry I want you to fold. And it often will keep them busy. They did that to me when I had my hip replacement. Gentle hand massage, therapeutic touch is very, very important for these patients. Hopelessness probably is more for the caregivers and family versus the patient because we want to support that family bond. We want to make sure. One of the things that's starting to become more and more prevalent is that, I love this quote, it says, it used to be that when men said, I'll always take care of my mother, it meant my wife will always take care of my mother. But now more and more men are doing it. What we're starting to see is that there are more male caregivers. In fact, basically the last statistic that I saw was that up to 40% of your patients with dementia are being cared for by men. There is a national support group because it is one of the things that's still somewhat rare. And often these men don't get the support that they need. Caregiver role strain is going to be one of your big nursing diagnoses that you'll see. Meals on Wheels, respite care. I know a lot of you do respite care as part of AIA. So those are definitely needs. And one of the things that has changed in the past couple of years is that patients with dementia are eligible for hospice care in their final stages. So please make sure that the referrals to hospice are made for the support of these families. Okay? All right, I think that's about all we're going to do. Except I have a few questions if you want to review. If you want to go, you can go. But just need help for next week. Sorry I ran long. All right, nurse assessing a patient with suspected delirium will expect to find that the patient's symptoms developed. What is the answer, guys? A, over a period of hours to days. Remember, delirium is fast onset. Of the following outcomes, which is more appropriate for a patient with cognitive impairment related to delirium? The patient will
C.
D, return to the pre-morbid level of functioning. Remember, we want delirium to go away.
Oh.
In caring for a patient with late Alzheimer's disease, which nursing diagnosis demands the nurse's highest priority?
A.
A, risk for injury. Safety is always your priority. Psychobiologic agents showing promise for the treatment of cognitive impairment associated with Alzheimer's disease include A, cholinesterase inhibitors. When will we give SSRIs or trazodone? Depression. Lastly, nursing staff that care for patients who are cognitively impaired can develop burnout. Strategies to avoid the development of burnout include A, setting realistic patient goals. All right. Good enough.
What is that?
Make sure you get boarding to